Okay, so here we're going to talk about infections by human immunodeficiency virus. Human immunodeficiency virus is the cause for acquired immune deficiency syndrome. And this is a retrovirus. Retroviruses have reverse transcriptase. Reverse transcriptase allows the virus to go from RNA to DNA. So RNA is the genome of the virus, and then the DNA is going to be able to integrate into our genome. It also has long terminal repeats, and these are very strong promoters. And these are going to recruit our RNA polymerases to make a lot of genes for HIV. It's also going to form syncytia, which is a fusion of infected cells. With neighboring cells. And this is a common feature of many viruses, and this is a way for them to hide as well as to get more resources. It's going to infect our CD4 T cells, and this is going to lead to immune suppression. And it's going to infect our macrophages, and this is going to be important for transmission. Now, HIV transmission, there are some known routes, of course, through body fluids like blood, sexually transmitted, or perinatal. So transfusion of blood and blood products, HIV is tested for now in most countries to make sure that the blood is clear of this infecting agent. Needle sharing among intravenous drug abusers is still a very common risk factor. For healthcare workers, it's a needle stick or open wound or exposure of a mucous membrane to patient secretions who potentially are infected, and then dirty tattoo needles as well. Both anal and vaginal intercourse can spread HIV, and perinatal is intrauterine transmission, peripartum transmission, as well as through breast milk. Routes not involved in transmission are close personal contact, household members, healthcare workers not exposed to blood. Now, HIV is going to be transmitted naturally sexually, and then they're going to divide in the mucosa. Now, remember, in the mucosa, you have your macrophages as well as your CCR5 CD4 T cells. So the infection is thought to be a CCR5 tropic virus, because in the mucosa, you are going to have the chemokine CCR5. So the virus needs two receptors. And you're going to need, one is going to be the CD4, and two is a chemokine. And it's going to be either CCR5 or CXCR4. And so in the mucosa, CCR5 is the dominant chemokine, so it's thought that the CCR5 tropic viruses are going to be predominantly the ones that are going to be transmitted. Now, once you do get the virus infection, and your cells are going to be able to move around. And so your cells infected with the virus are going to go to the lymph nodes, and they're going to spread, the virus is going to spread to other cells in the lymph nodes. You're going to get acute HIV syndrome, which means you have a large viremia. Viremia, of course, is virus in the blood. And this can be used for diagnosis. And then the blood is going to transmit the virus further. So basically, in acute HIV syndrome, you are going to get transmission of the virus into the central nervous system, but this is going to be mild and the disease goes chronic. in your central nervous system. And this doesn't cause any problems until you get to AIDS. And this is where you get AIDS dementia. So this is years later. But the virus had moved in there during the acute stage. Now, also after the acute stage and you get your virus under control, you're going to move into a asymptomatic level of HIV viremia, meaning that your body keeps it under check, but it's still present. You're going to get persistence in your lymph nodes, lymphadenopathy, and these are going to be CXCR4, CD4 tropic viruses. So the CXCR4, CD4 T cells get targeted. You then get another round of viremia, and you get severe immunodeficiency if your CD4 T cells drop to below 200. So you get a drop in CD4 cells, you get a drop in CD8 cells, and then you progress to the disease. Now, when you look at this from the perspective of viruses as well as your immune system, you can see that you have your CCR5 virus, which is going to predominate very early through a few years. This is going to shift when you're going to progress to AIDS to a CXCR4 virus. So it goes from CCR5 to CXCR4. And so your CXCR4, CD4 T cells are going to be in the periphery, and once those guys get infected and you lose most of your CD4 T cells, then you're going to progress to AIDS. Now, your acute infection, your virus is going to peak. You're going to use a protein called P24, is going to measure virus titers. And this is just a protein that your virus makes, and it's easily detectable. And so that's used to diagnose someone who's been in the acute phase. Now, of course, your virus is going to go to levels that are below detection until you lose control of the virus, and then they peak again, and you can measure the P24. Now, you're going to, of course, have antibodies that come up, and so your antibodies are going to come up, and they're going to stay relatively high until you lose control of the virus, and then they're going to drop again. Your T cells and CD4 T cell count is going to be initially high, and then as you progress through AIDS, it's going to decrease, and when it gets below the threshold of 200 cells per cubic millimeter, you are going to progress to AIDS. And so you have up here, you have an acute infection, and this is going to be followed by a chronic lymphadenopathy, latency where the virus is sort of below limits of detection. You have subclinical immune dysfunction. Again, the virus is still under check, under control. And then you're going to get systemic immunodeficiency, and this is where you lose control and you progress towards AIDS. Now, typically, you're not going to die from HIV. You're going to die from a secondary infection. And so over here, you have secondary infections. You get pneumonia, you get meningitis, things of that sort. Now, HIV is a positive RNA genome. It's going to have its own RNA-dependent RNA polymerase as well as reverse transcriptase. It's going to have integrase, which allows it to integrate into our genome. And you're going to have these proteins, all these fancy proteins shown here in a very small genome, and they do this by overlapping, which I'll show in just a moment. And here's your capsid P24 antigen that's very stable, and that's what's used for diagnostics. Your envelope proteins are what are going to bind to your CD4 and and your chemokines, CCR4 or CXCR4, especially that GP120. GP120 is glycoprotein 120, which will bind to the receptors and initiate infection. Now, HIV has two different types. There's HIV-1 and HIV-2. HIV-1 is the one that we are most interested in and is what's causing the current pandemic for decades now. We have several proteins that are very important in HIV, and you can see that they are going to overlap each other. All these genes overlap, so we have alternative splicing for making these proteins. We have a protein called VIF, which is virion infectivity factor. This is going to be important in virulence of HIV. This interferes with a cellular protein called ApoBec3G. ApoBec3G is a natural sort of antiviral protein inside of our cells. And so HIV has evolved to counter ApoBec proteins. GAG is going to be for capsid proteins, again, important for the structure of the virus. Polymerase is going to transcribe reverse transcriptase, as well as other polymerase genes. Our envelope is going to have the tropism proteins on its surface. So the glycoproteins 120, for example, which will bind to CD4 and the chemokine, and GP41, which will help to initiate fusion with our membranes. There's going to be a series of regulatory genes. We have TAT, REV, NEF, etc., etc. All of these retroviruses have these long terminal repeats at each end, and these long terminal repeats, again, are going to be important for regulating genes as well as recruiting host RNA polymerases to make their genes. Now, HIV can escape from the immune system because it has a lot of mutations. So you are going to have infection of our actual immune cells. So in this case, you have infection of our dendritic cells, macrophages, and our CD4 T cells. So our dendritic cells and macrophages are our activators. So they are going to activate your immune system, whether it's a virus, fungus, parasite, or a bacteria. And then your CD4 T cells are controllers. They're often called helper T cells. And so they're going to help make sure that the immune response is correct if you have a bacteria infection versus a virus infection versus a fungal infection, etc. So because these are going to be targeted by the virus, you're going to have a loss of your activators and controllers. You also have mutations, high mutation rates of our GP120, and this is going to change or require our B cells to have to constantly be changing their antibodies. And remember, B cells need CD4 T cells. So when you lose CD4 T cells, you're also going to lose the ability to make antibodies to keep up with HIV. There's also going to be heavy glycosylation. Glycosylation is adding sugars to proteins. And sugars kind of coat the proteins and they hide the proteins from the immune system and from antibodies. You also have that syncytia formation we talked about, direct cell-to-cell spread, which can evade the antibody response and evade neutralization of the actual virus. Also keep in mind that HIV integrates into the genome. And so because of this, every single infected cell with the integrated HIV genome must be detected and killed. And this is a problem during latency and also when your HIV falls to below limits of detection. It's just kind of hanging out. So AIDS, or acquired immune deficiency syndrome, is going to develop when you have the CD4 T cells drop below 200. And your CD4 T cells, again, are going to be important for many things in your immune system. And once you lose them, you lose all these important things. So CD4 T cells are your helpers. And they are going to help your B cells. They're going to help your natural killer cells, CD8 T cells. They're going to help in the control of viruses, intracellular bacteria, tumors, etc. They're going to activate your innate immune response and control bacteria, especially those extracellular bacteria and fungal agents. And they're important in releasing growth factors for just normal homeostatic type of immune function. Now, HIV is going to be primarily transmitted sexually. That's its natural route of infection. However, It can be transmitted by blood because IV drug users or blood transfusions can transmit the virus. Diagnosis is going to be by reverse transcriptase PCR for looking for the genome. There's a quick test also for looking for that P24 protein that HIV makes in the blood, and you can detect that in the blood. Treatment is going to be through nucleoside analogs as well as protease inhibitors, reverse transcriptase inhibitors, and it all comes down to heart, where you have a multitude of drugs that you're going to give to try to prevent escape from the treatment regimen. Now, prevalence of HIV is going to be most prevalent in Africa, and so you can see that's deep red. And you can see that the Americas is right next to it, so it's orange. However, if you actually look at the prevalence, you can see Africa is 4.1, and the next prevalent is the Americas at 0.5. So this is a huge burden in Africa.